Hello, everyone. You have joined us. I hope you are in the right place. Welcome to our quarterly webinar. Today's topic is an ecosystem approach to behavioral health integration, blended models, and just the continuum of care. I am Monica Harrison with the AIM Center. I'm joined today by my AIM Center colleagues as well, Sarah Barker and Sydney Fosnick Davis. The AIM Center helps support organizations implementing the collaborative care model through coaching and clinical training. Since 2017, we have also developed technical expertise in billing and financing collaborative care and have gained national recognition in this arena. The purpose of the AIM Center is to inspire providers, researchers, and decision makers to transform healthcare and improve patient outcomes. We accomplish this by translating and researching evidence-based approaches to behavioral health integration. This call is being recorded, and we'll be sending out a link to the recording and the slide deck to everyone who has registered. The webinar format accommodates our very large audience, so you'll see on your Zoom screen, there is a Q&A function. We're asking you to use that instead of the chat. You can enter your questions for the presenters at any time. Today, we'd like you to focus questions on the experience of these expert presenters that will be talking today. And if you do have just general questions about implementation or financing of collaborative care, please bring those to our implementation or financing office hours. You can also check the FAQs on our website, and Sydney is going to be putting those links to both of those in the chat for you. At the end of the session today, participants should be able to describe the behavioral health ecosystem in the context of primary care, identify the core components of collaborative care and how they align within the larger behavioral health ecosystem, and also examine real-world examples of combining integrated care solutions, such as collaborative care and primary care behavioral health. Today's fabulous presenters are Drs. Anna Rotzliff, Beth Zidler-Schreider, and Laura Sadari, who will each provide a quick introduction of themselves and their organization when they speak. So let's get it rocking and rolling. First up, let's set the foundation for today, and I'm going to turn it over to Dr. Anna Rotzliff.
All right, thank you. Really excited to be here. So my name is Anna Ratzliff. I'm a professor and psychiatrist at the University of Washington, and I co-direct the AIM Center. And I've spent basically the 15 years of my career both working as a psychiatric consultant in a collaborative care team and in my work at the AIM Center, really helping to promote and disseminate integrated care models, help organizations really build capacity to actually deliver mental health services in primary care and other medical settings. So I'm excited to kind of present the introduction to our two fabulous speakers and really want to lay some foundation around how might we start really thinking about more of an ecosystem approach to delivering mental health services. Let's go ahead and go to the next slide. So what do I really mean when I'm talking about the behavioral health ecosystem? And I think this is something that I've really been thinking about a lot recently, is that as we have really had a big shift to have more expectation that we can provide behavioral health services in primary care and other medical settings, we really have to start thinking about what are the needs of those systems and what kind of care can we really provide effectively there. And in order to think about that, I think it's important to think about the whole range of behavioral health approaches that patients may need. So let's go ahead and start on the first slide. I really think that it's always foundational and really important to talk about the fact that a lot of patients who are experiencing mental health concerns or behavioral health concerns are engaging in self-care. In fact, probably the vast majority of people really start there. And this might include things such as getting community resources. For example, this could be getting support from a community or spiritual advisor. This could be getting involved in actually using some of the numerous apps that are out there to help support your mental health or behavioral health changes, as well as self-care approaches that include things like exercise and diet and sleep, right? So these are all things that people might do on their own, but are a really important foundation to any behavioral health treatment that they may be getting. Let's go ahead and go to the next slide. And then when you get into working in medical settings, what you really start to see is that there are a number of strategies that people are using to deliver services. So this is really a summary of, 25 years of evidence related to people trying to think about how we might better deliver services in primary care settings. So many of these approaches include team-based care. This would include the collaborative care model. So really bringing in new people to the primary care or primary medical setting, often with behavioral health training and skills that can help support those primary care providers. This can include delivering behavioral interventions, especially brief behavioral interventions, right there in primary care where people are used to receiving their treatment. And a number of the models that we'll talk about use this strategy to support patients. This could include supporting medication management. Many of their patients, in fact, the majority of patients actually receive their psychotropic medications from primary care. And this could include approaches like panel management. And I think when you think about the collaborative care model, for example, it really uses all of these strategies and as a way to organize delivering all of these strategies to patients with diagnosable mental health conditions. So we'll also hear a little bit about the PCBH model today, and that also uses a number of these strategies. So with purpose, we are not actually listing models here, but rather listing functions that a primary care setting may be able to deliver. Let's go ahead and go to the next slide. And finally, it's important to recognize that we probably can't address, and I will never say that we can address all of the behavioral health needs in primary care settings. Many patients will need specialty behavioral health services and may need to get those services in behavioral health settings. So again, this can include more complex medication prescribing, maybe patients who need more ongoing monitoring and support around medication management and adherence. This could actually be more intensive behavioral interventions. I will say some primary care practices do offer these services in a co-located model where they actually offer those in primary care, but more traditionally, we see these delivered in behavioral health settings. This could also include all the support that is available through community mental health services, which might include things like rehabilitation, some of those services that especially for patients with more serious and persistent mental illness might actually benefit from. And then, of course, all of the kinds of highest levels of care that patients may need, including inpatient, partial hospitalization, and intensive outpatient services. And I think it's really important to think about, as you start to build out capacities, you have to really think about what are the services you can offer in your setting across this ecosystem. Go to the next slide, please. And we put that patient in the center because I think a really important concept when we start to think about the behavioral health ecosystem is to be thinking about how are we actually going to support the whole person in any of these settings, and especially how might we support really building out transitions and coordination across these different levels of services. So those will be important concepts, I think, to be listening to as we listen to our two great speakers today. Let's go ahead and go to the next slide. So one of the things I've been thinking about a lot is how do we really develop more of a strategic vision for this behavioral health ecosystem, as opposed to just kind of implementing different things and different pieces at different times? Are there ways that you can be more strategic in really developing out the capacities across the spectrum within your own care setting? So I really think of this as having three pieces that are really important. The first is really doing a good needs assessment. What are the needs of our population? Who are the patients in our system who need behavioral health? What age range are we going to be able to, address the needs of? Are there specific populations within that group that we might want to be able to help? For example, patients with diabetes or patients with HIV. And then what kind of care are our patients really needing? What are their diagnoses? Is this actually more around health behavior change, or is it more around addressing diagnosable mental health conditions such as depression? Could this also be, for example, in pediatric populations, counseling on common um, caregiver and family supports that patients may need? And what are the priorities in our primary care, other medical settings, if we can't address all of those things? So that can be a really important question to ask, because at least my experience is that in most settings, is more need than we have necessarily capacity for. So thinking about how, as an organization, are you really going to assess those needs? And then the next part, go ahead and go to the next slide, is to really start to think about what resources do we have available in our setting. Do we have things like infrastructure, like digital tools or a registry or other capacities within our EHR to help support patients? And then who are the people that we already have that can help deliver services in these settings? Are there people in our team that can deliver behavioral services? A wide range of people can actually do that or be trained to do that. Who are the people who are really good at coordinating care and addressing social needs? Maybe they don't need to be formally clinically trained or licensed, but could actually provide a lot of that work. So thinking more from a functional perspective, and then instead of a specific name or role for a provider. And then who in our team can prescribe medications? For example, many primary care providers can prescribe medications, as well as some of our, the psychiatric providers may be able to do that. And I think when you're thinking about this, one of the things that can often come up is, what are our gaps? Are there areas that we actually need more capacity? And how are we going to use our compelling needs assessment to actually advocate for additional resources? Is there any capacity to do that? And then finally, as we now have a good sense of who are the people that we want to serve, what are the needs of that population, and who are the people we have to actually deliver services and provide care, it's important to start thinking about, how do we put that together in a really strategic way to address those most urgent or priority needs? For example, are we going to use a specific model of care? Do we need to develop some capacity to actually deliver direct services? Or maybe we need an opportunity to build a partnership with someone in the community who we can do more facilitated referrals with to be able to address some of those needs. And then once you have those in place, how do you really develop the clear roles and workflows and billing strategies to support that whole ecosystem of care delivery? And I kind of give this framework because, as you're listening to the two presenters today, I think there'll be a real opportunity for you to sort of hear how they were able to do this, and how they built out teams that could actually support a wider range of behavioral health services. Let's go ahead and go to the last slide. And I just want to kind of emphasize this point that, different approaches to integration often are addressing different needs. And that's why I think it's so important to really start with, what are those needs, and then think about what models you might use. For example, our PCBH models often are addressing any biopsychosocially influenced health condition, so a much wider range of presentations. They often used a more generalist behavioral health consultant, who typically is an independent behavioral health provider. And they often are focused on rapid access and warm handoffs. That's very different than the goals of an episode of collaborative care, which was really designed and tested to address diagnosable mental health conditions, has a much more structured, formal roles for a team members, and often delivers care, an episode of a care over several months to be able to address the diagnosable mental health condition. And then many places have some component where they also deliver direct services. So this might be more intensive psychotherapy or ongoing medication management. This could be somebody who either has expertise in psychotherapy. So, for example, a psychologist or licensed social worker who's really trained to deliver, for example, evidence-based treatment for a trauma disorder. It could be a psychiatric prescriber, such as a psychiatrist or psychiatric nurse practitioner who might do more direct prescribing. And sometimes it's really important to be clear what percentage of somebody's time is being spent maybe supporting a collaborative care team versus giving direct service delivery. So I'm hoping that this framework of a couple of big ideas, right? First, how do we actually create an ecosystem? And second, how do we do a strategic assessment of what the needs are in our setting, to then be able to draw on what are evidence-based, effective strategies that we might use in a strategic way to meet those needs. And I think what you'll hear from our two presenters today is some really nice examples of both how they built out that capacity, what were some of the common things that they maybe struggled with, and how did they address those to really build out the whole capacity of their teams to deliver excellent behavioral health care. So I'll pause there and pass it off to our first presenter.
Thank you so much. Hi, I'm Dr. Beth Zeidler Schreider. I am a psychologist by training, and I'm the Chief Behavioral Health Officer at Access Community Health Centers in Madison, Wisconsin. I'm also a clinical assistant adjunct professor with the University of Wisconsin Department of Family Medicine and Community Health, and spend time in one of the residency training clinics that's affiliated with Access. So wanted to give an opportunity to just hear a little bit about the work of Access. Access is a federally qualified health center, FQHC, also known as Community Health Center. It's about a medium size, roughly 30,000 plus patients served annually. And we have a long-standing history of the primary care behavioral health model. Our program started back in 2006 with a psychologist of one, and then has grown to a team of approximately 20 in 2025. We have a consulting psychiatrist. We have actually 13 behavioral health consultants that are psychologists and social workers, which equates to about a 10.5 FTE. We have 3 behavioral health care coordinators that are bachelor's trained team members. And then we also have fellowship programs. So we have 2 current social work fellows, 1 current postdoctoral fellow, and then with our collaboration with the University of Wisconsin Department of Psychiatry, we train 10 of the third-year psychiatry residents annually in how to be a consultant, how to be a good educator and team player within the primary care setting to, again, extend that knowledge to the larger care team and really, I think, stretch the reach and impact of the psychiatric consultant. So as I mentioned, back in 2006, we started our PCBH program, but we went live with the collaborative care program in August of 2023. And this was really crucial because we were very active with our Wisconsin Medicaid office about ensuring those codes would be covered. And so with that advocacy comes when you ask for it and it is approved, you want to make sure that you're using it, that you're implementing it, and you're leveraging the use of those codes. And then in August of 2024, we went live with General BHI, which was the other code that wasn't initially part of the approval in the state of Wisconsin, but was added later for those 20 minutes of behavioral health care management services. So we're coming up on 2 years for CoCM and 1 year for the General BHI care management services. And we provide these services across our 3 primary care clinics here in Madison, Wisconsin. So I think it's really important when we think about like, why did we add CoCM? We had this like very robust PCBH program already. And I think there was a lot to be said for how our PCBH program was thriving. And we wanted to be able to really harness the power of collaborative care. And so we actually sought out expert technical assistance. And I think that's important to just name on this call, is that none of us are experts in everything. And so how can we be curious? How can we ask questions? And how can we pull in additional supports when we need them? And the aim of this was to really integrate CoCM as a seamless part of the array of services we provide within primary care without having drastic changes for our staff, honestly, for our PCP colleagues. It was really important for them not to have to do the mental gymnastics of when do I refer to CoCM, when do I refer to PCBH. And so our message was clear. You refer to your friendly neighborhood BHC. And that neighborhood BHC then that's in your clinic would decide, does this make more sense for us to maintain and see within our PCBH program? Do we see them for a little while and refer into CoCM? It didn't have to be an either or, it could be a both. But how do we make sure that we're there to support our primary care providers in really streamlining that decision-making process? And that comes to the second point, which is reducing provider burden. One of the core tenets around the PCBH model is our primary care colleagues also being one of our primary customers in addition to the patient. And so how do we make sure that we're trying to help support their job being easier by providing the most robust care collaboratively with our primary care colleagues? And then we were also really thinking about like, how do you streamline workflows? And I think this is really important. Within our setting, we had really clearly defined roles. So my BHCs are functioning as BHCs within PCBH. We have separate BHCCs, which are behavioral health care coordinators. They're functioning as that care manager within CoCM. And these are separate roles and separate individuals doing that. Because I think it's challenging to try to wear many different hats in that way and try to parse that out to really minimize any concerns around dual roles or confusion around what am I doing when. And I mentioned this one already, but the guidance and support piece I think is crucial. And so when in doubt, reaching out to a plethora of experts within the community. Obviously, there's the implementation support from the AIM Center and other things to make sure that you get the support you need and provide training to promote success. And I wanted to just highlight what we've seen as the benefits. And, you know, Anna hit on this around the PCBH approach being that of a generalist, right? So we're open to seeing everything that you're seeing within primary care across a lifespan, which was really important given the work we do within an FQHC. The addition of CoCM, though, allowed us to better support our patients that had specific defined behavioral health conditions. And in our setting right now, we're only doing that with depression and anxiety, but obviously CoCM has reach for a lot of behavioral health conditions, and ensuring that we could have a systematic process that was registry driven, making sure people weren't falling between the cracks, and really giving opportunity to expand and diversify our care teams. So as I mentioned earlier, our BHCCs, or our care managers, they're bachelor's level trained in motivational interviewing and other evidence-based interventions to really support patient engagement, behavior change, and they are a key team member in working with the patient alongside the BHC, PCP, as well as our consulting psychiatrist. It also has allowed opportunities for career pathways, for growth, for advancement, and for drawing more individuals to join the primary care team. So just a few quick lessons. I think one of the things is really important, as Anna talked about, but being clear on what the aims are of your program and choosing models that align with those goals. Ensuring you have administrative buy-in initially, but also ongoing when you're thinking about how do you scale and sustain this. Also being really mindful, as I mentioned earlier, around the clear role definition and having consistent workflows when you're leveraging both models, because the role definition piece is really crucial. It's important for obviously the care team members, but it's also really important for the patient perspective, for them to know what they're receiving and who on the care team they're going to be engaging with. I highlighted this earlier, but technical assistance, again, I think is key in reaching out to other experts. And then the last thing I really wanted to highlight are the benefits of advocacy. and partnership with payers and your state Medicaid office to support the fiscal sustainability piece. So as the Chief Behavioral Health Officer, I'm also in charge of our budget. And so as much as I'm like, I want to hire more care managers, I want to do more here, one of the ways we can do that is we can also be talking about how do we grow this to reach more patients and to optimize patient outcomes, but how do we also grow this in a way that's fiscally sustainable and allows us to add more team members so that we can have even greater reach. I'm going to turn it over to Laura.
Thanks so much, Beth. A lot of what you shared is going to resonate with what I'm going to share as well. I'm Laura Sideri. I'm a general psychiatrist with 10 years expertise in integrated care delivery across military, college health, and community care settings. And I'll share with you today my journey with Cayuga Health, which is where I work clinically as a service director and integrated consulting psychiatrist since 2021. Nationally, I also work as a medical director for integrated care for CFHA and also work as a technical consultant, helping teams ranging from professionals to organizations translate the evidence-based into strategies that fit for their individual organizations. All right, go ahead. So in 2021, in the middle of the global pandemic, I pitched this wild idea to the CEO of Cayuga Health System, asking if they might need integrated care services for the community. I was working in college health at the time and really saw this need in my larger community for mental and behavioral health supports. The question really began when, Cayuga said, yes, what are the needs? And it's more than just my perspective as a community member, but really bringing together a multi-stakeholder group to help inform that, ranging from individuals who are in the health system to community members. What Anna shared related to the strategic vision and process organically happened for Cayuga Health. It wasn't as nicely outlined in those multiple steps, but really had an understanding that we needed to first begin with that needs assessment, looking at the population, looking at the different mix of specialties, practices, what are the opportunities and limitations. Some of the things that came to light doing needs assessment in the first 3 months was talking with various stakeholders ranging from the community mental health clinics, ranging from patients, talking with health system partners and talking with primary care teams, was that ultimately we had very, very limited specialty mental health supports. Outside of the county mental health systems that we had for the 3 counties that Cayuga Health serves, there was very, very limited fee-for-service, mostly pay out-of-pocket options. So really limited in terms of that stepped-up care. Right from the beginning, the multi-stakeholder focus group that collected, we started with beginning with a mission and vision statement. And ours really highlighted accessible, affordable, integrated care as our starting point with a focus on supporting primary care. And we identified our clients both as the primary care providers as well as our patients, community, and neighbors. A huge part of this initiative and our goals was also focusing on localism. This piece that we wanted to have those locally supporting this initiative and serving those that our staffing also was supporting. Population considerations, we identified 65,000 primary care patients in the network. And at that time, Cayuga Health Larger had multiple individual standalone small group practices that were contract-based considerations, as well as Cayuga Medical Associates, which was an internal professional corporation, not for profit. So we had to think about what would also be the contracting considerations, what would be the ability to engage and work as integrated team members. We also had to think about, as part of our needs assessment, what's the way to show value? And so the needs assessment process is not just to check the box. It was really looking at what's the way that we can build relationships in this process, capture baseline data, and be able to see opportunities as well as limitations. And so in the needs assessment process, working with 7 different practices, we were able to rank based upon levels of integration and kind of opportunities in areas that have been shown in the literature to be challenging or helpful for integrated care, to determine 2 key pilot sites. I would say with this process, if you're going to be working on initiating integrated care, it's important to start with what are the needs and what are the limitations. The other piece that we were able to do was use that to eventually show value as our baseline metrics. The next part that we moved on to was looking at what are the resources that we have now versus available in the future. I was fortunate to have 2 clinical psychologists that were coming on board with me, so that helped to inform service selection, service delivery. We also, since we hadn't built out or coded any of these different opportunities, really had to look at those pieces. With those implementation considerations, what became apparent with the needs assessment process, and what I'll emphasize to the group here, is always begin with who should you involve in service development, both in that needs assessment process, building buy-in, building championship, as well as the actual delivery. Look at what are your priorities and resources. Make sure that you're looking at what are both the opportunities and limitations, because that's going to inform service development. Then you should move on to that piece of how should you construct your initial services. Looking at the opportunities, with such limited specialty mental health, we really needed to define and devise integrated care that could fill a wide spectrum of the population. So we had pediatric patients, we had elderly, we had general adults, we had highly educated professors and individuals who are part of the community college health system. And then we had individuals who are in rural communities with really limited social determinant of health supports. So a combination PCBH and CoCM model was really helpful for us right from the get-go, because we were able to serve both the in the moment needs as well as the longer needs. So in defining and devising how we brought CoCM and PCBH together, we looked at both what are commonalities, things that we could do in our workflows and in our processes to bring care together, and then also what are ways to separate that out. Since we hadn't had any billing or coding experience with behavioral health in the health system, technical support was instrumental. New York State offers free of charge for collaborative care model technical support. So we were able to use that a lot to get collaborative care up and going. We use PCBH in the office using a behaviorist, an LCSW, or a PhD, largely because they can be credentialed and licensed with our payers to provide for any primary care need, brief intervention, 1 to several visits, and they can really serve any piece of that wide range of primary care behavioral health supports. The problem is with PCBH, if you don't have any outlets, like we didn't have specialty mental health, you can easily end up with co-located care for those more ongoing needs. And that's where collaborative care model came in. We utilize virtual collaborative care using separate BHCMs and BHCs. And that focuses really on the most common needs of anxiety and depression. We're also exploring ADHD as another one. There's billing and coding challenges with that still being explored. And this is for more ongoing, but still not long-term support. So really focusing on 3 to 6 months focused intervention. And as the consulting psychiatrist, I do weekly SCRs, 2 hours with each of my care managers, being able to make sure that we're also providing that level of care. The key things with development of these workflows is 1, making sure that we have a shared consent process for both services. Similar to Beth, if we don't know which service to start with, we're going to start with BHC. However, we do have the option for people to directly go into CoCM. Another key consideration is we look at recommendations for care based upon the patient's need, not just the patient. So some patients might have both PCBH and CoCM support. Some may only have one, some may have neither. This really allowed us for a diverse 65,000 patient population to be able to tailor services. All right, go ahead next. So in terms of lessons learned, right now we're in 6 practices, 4 clinical sites serving 40,000 patients. We have, in the long term, looking to fit the full 65,000 patients. So when we're looking at what is the goal for the health system, look at upfront and ongoing investments. I was really fortunate that Cayuga looked at integrated care as a long-term investment, and we were able to have, although there were more upfront costs, investment in doing a thorough needs assessment process, gathering buy-in, gathering championship, which is allowed to have a sustainable model set up as opposed to sort of piecemeal. If I didn't have that really strong support with investment, we would have had a much different approach, which I don't think would be now heading into our 5th year as successful as what we've been able to see. Also, it's important to highlight the difference between passively accepting versus championing BHI. Ultimately, this serves the primary care partners that we are one part of the primary care team with. And our PCP champions are huge. At each of our practices, we also highlight a practice manager champion, a front desk champion, a clinical support staff champion, our primary care champions. And this is different from just attending meetings or saying, you know, I'm all right with integrated care. This is showing, advocating, really, you know, finding ways to best use the services and the models that we have, as opposed to maybe offering competing models or saying, well, I'll just go along with it. True championship is incredibly important. The other piece is make sure that you're always looking at every opportunity as a process more so than an outcome to engage stakeholders. There can be a lot of frustration with, let's say I'm not invited to the table to talk with certain stakeholders, or let's say certain stakeholders have a difference of opinion. If we look at engagement as more so, every opportunity that we engage is an opportunity to be able to build relationships, to be able to build sphere of influence and buy-in, that can have much lower levels of frustration than going specifically like, I need to just get more staffing, or I need to get this model pushed through, or other pieces like that. So really encourage that relational approach of investing in the process, and the outcomes will come as you do that. Look at opportunities to have clear, streamlined workflows whenever possible. And we've really taken this approach of building off of primary care workflows. A lot of the problems that have come up with service development have really not been IBH specific. It's been, we see a loophole or we see a problem with team-based primary care workflows. And so engaging all stakeholders, really working to make sure, where can we automatize, where can we like kind of have those clear workflows for screening, for consenting, those things that are part of every day are huge. The personalization really comes in that patient-centered care, that choosing of which model to activate when. That's where you can have those more flexible pieces, but I really encourage identifying a clear workflow for your main everyday common processes. Also keep in mind, traditional care has a huge influence on difficulties with IBH implementation. People are used to, as part of like medical training, myself included as a physician, you maintain care until you can't handle it anymore, and then you refer out. And that's been very much ingrained in the primary care space. That traditional care model is very different than integrated care, where we're really encouraging people to make requests and recommendations for care before they get to that level where they can't take it enough. And so just being mindful that that pressure of what's the norm and what's comfortable is an ongoing challenge. So look at opportunities to have continuous training, continuous education, and modeling at every level, from huddles to meetings to in the moment care and your workflows, the difference between IBH and traditional care. And the last part I'll leave you with is get creative in showing the value. There's a lot of emphasis on reimbursement structure. What are the codes that we need to do? Fee-for-service is still a dominating model. But for instance, especially for collaborative care, we also see value for PCBH. Reducing unnecessary hospitalizations and ER visits is a huge part of what shows the value added. Increasing screening rates, improving HEDIS measures. Look at what's in the contracts for your health system, advocate for other pieces for value-based care. Try to build out a robust pro forma. The other piece is looking at what's the value for patient and provider satisfaction. What is the value added for your care system? How does it align with their values? Always look for these creative ways to capture and use data that you're collecting and show the value. All right, next slide.
Okay, well, wow, that was a lot that you all gave. Many thanks to all of you presenters. It's always so valuable, I feel like, to hear from those who are stepping up to kind of figure this thing out. And what I hear most importantly is there's not one way to do it. if you are wanting to make sure you are providing the best possible care to the patient population you serve, the importance of thinking about that needs assessment to know what do I need to have in my behavioral health ecosystem at my organization. And I also heard, especially Laura and Beth, like hear you guys talking about like the stakeholders and advocating and building these relationships in the community, because that's important and that's helpful, even though you're providing services already in-house, the importance of still making these other connections that are far beyond just service delivery, but also the advocacy piece to keep things going. So thank you all for that. And thank you all for being willing to share kind of your lived experience and thought on this. So we are going to shift over to our Q&A section, where it's just time for questions. And so Sarah has been taking a look at the Q&A box, and I know that we also had some additional questions that have come in, so we'll see how many we could get to, but encourage all of you all to share your perspective on those. But Sarah will read from the questions that were submitted, and then our presenters can respond.
Great. Thanks, Monica, and thanks so much, panel. The first question I think is for you, Dr. Ratzliff. When you were showing that behavioral health ecosystem graphic, there was a question around pediatric populations. And for pediatric populations, where would you place school-based mental health supports and also parent family mental health supports?
Yeah, I think this is a really important question as we sort of think about different populations. I think they could be placed anywhere on that spectrum, right? Depending on sort of what function they were serving. So if they were more the general support that schools give kids, maybe that's more in that self-care community support kind of realm. If they are more formal, like an integrated school-based mental health kind of program, that probably looks a little bit more like what you see in the primary care section where you're, working on brief behavioral intervention. So maybe you expand that to be like primary care and school-based settings, right? A lot of times those are connected to primary care clinics in those settings. And then there are settings where sometimes that tips over to where there is like a community mental health organization that is partnered with schools. And then, that might be services that even are falling into that sort of third category of more intensive services, direct behavioral health care, especially behavioral health care. So I think as you think about whoever's in the middle there, that would probably include the family and caregivers when you're thinking about pediatric populations. So that a need to coordinate with all of those resources is going to probably be even just more important when you're talking about pediatric populations. But I know Dr. Sadari and I think Dr. Zedler also has pediatric patients that they serve. So I don't know if they have additions to those comments.
Any additions? Yeah. Any other additions to that question, or shall we move on?
I thought Beth came off of mute, so I wasn't sure if she was getting ready to share or not. Oh,
Oh.
Beth, we can't hear
Oh,
you
no.
for some reason.
You can't hear me?
Now we
Oh, wait,
can.
there you go. There you go.
Good. I was like, I unmuted, I swear. No, I will tell you that we've actually had really good luck in starting to use more of the general BHI care management codes, particularly for our pediatric patients, and coordinating with schools, with goals being related to IEP development, accommodations, assessments related to ADHD, both with the direct outreach, right, with the patient and the family, but also all of that other time that is spent to coordinate collateral information with teachers, with schools. That has been huge for us. And it's been a really important way that we've just actually been fine-tuning some of our workflows. And we just tweaked them a little bit more in preparation for the fall, because that is always when we get an influx of more referrals in the context of return to school and those types of things. And so I think for us, that has been one of the biggest ways. But I also think PCBH and the collaborative care is not a replacement, right, for those specialty services that we saw on the front slide, because I think they augment each other, right? And it creates capacity when you need more specialty care, when you can manage as much as possible within primary care. But it's not that replacement. And I think that every step on that continuum serves a very valuable and important role in overall health and wellness related to behavioral health conditions.
Great, thank you. All right, should we go to the next question?
I think Laura was getting ready to say something,
Yeah.
Sarah.
Okay, go ahead, Dr. Saderi.
Yeah, I think just kind of focusing on that part of the ecosystem, that with that patient-centered approach, who is part of that patient-centered care plan? So when we're looking at kids, that family piece is very important, and that extended community piece is important as well. And so looking at the ways to leverage the model to hone in on that patient-centered, person-centered piece, which includes as an extension, especially for that population, caregivers, community stakeholders, and partners.
Thank you. We had a couple of questions come in around the consent process. So the first one is around curious with the central referral through the BHC for either PCBH or collaborative care, how the requirement is satisfied that the PCP consent the patient, because this is a requirement to build the collaborative care codes. So how are you handling that consent process when you go through the BHC?
Our medical provider is documenting that they are requesting, right, support from integrated behavioral health services. And so they'll document that they made a warm handoff that day to the BHC to review services. And so those services would be CoCM and or PCBH. We also have a global consent when all assignment of benefits that talks about behavioral health integration as part of that. And then once we make it, so that's documented by the PCP. And again, our coders have approved this. I encourage all of you to look at your own coding and compliance to make sure that your system is comfortable with this approach. But our PCPs have been more general in introducing integrated care, so PCBH or CoCM. And then once we are formally going to make the referral into CoCM, it is redocumented formally consent related to CoCM by that behavioral health care manager, noting that they received the referral from the PCP. And so for us, that was acceptable from our coding as compliance because it was generally introduced and documented by the PCP. And then it is reinforced with the patient related to cost sharing and all of those things that is documented specifically by the behavioral health care manager. Laura, I don't know if you have other things to add to that.
Yeah, very similar piece. I mean, I would say as part of your workflows, you really want to think about what are the ways to incorporate both clinical and administrative needs. So we have a universal consent phrase that meets the criteria for collaborative care. That's helpful for PCBH, even though it's not required for billing, to explain the team members as an extension of the primary care team, that there may be cost sharing involved. Myself as the consulting psychiatrist also can be curbsided, even if there's not like a patient specific question. So it introduces my role on the team as the PCP may ask me questions related to their care. So I would really encourage looking at this sort of shared workflow if you're going to combine PCBH and CoCM that combines the most important pieces. So we've used the APA's recommendation on the billing and coding practice sheet for CoCM, this consent. And this is what we utilize as a shared consent for both PCBH and CoCM services. So this would be, I would say, an example where even if this is a requirement for CoCM, it's still good practice for PCBH to have that conversation. So that's how we've approached that as a team doing combined model care.
Okay, great. We have a lot of questions coming in. I'm going to jump to the next one. Any guidance on how best to structure and onboard BHCs who will be serving in a dual BHI, PCBH, and collaborative care BHCM role as they pilot and scale integrated care across clinically integrated network practices?
We found it really helpful to adapt the available like national trainings, especially the high quality trainings through the AIM Center for localism needs. So I would encourage investing time and resources into having a formal onboarding process. It will save you time, energy, money, efficiency, headaches. our team, we looked at having a combined, like single person doing both roles versus separate individuals doing both roles. And we sought a lot of technical consultation for that. I would have to say, just think about the differences versus similarities in the roles. We ultimately determined there's too many differences between the workflow of what a BHCM, a care manager, would need to do, especially with remote monitoring, observations, registry management versus what PCBH needs, being more flexible, adaptable in the office. This also allowed us to have tiered different pieces for hiring, different salary levels, and ability to move up to a PCBH role as a promotional sort of piece. So think about that when you're designing your workflows and onboarding. What are the shared needs across one or multiple professionals, and what are the individual training needs? And I would encourage infusing in that a see one, do one, teach one. So you're going to be showing them how to do this with training, but then also have them shadow, have them do observed interventions, and then be able to do stuff on their own. This is where I think investing in leadership to do the onboarding and training and supports can be really value added, and making that business case with showing faster time to get up and running, the sustainability and retention piece. It's ultimately a really good long-term investment and helpful to show that to organizations that you're working with.
Great. A couple ones around kind of sustainment financials. Have you established both PCBH and collaborative care as financially viable models? And maybe too, as a follow-up, have you established productivity expectations for your positions? Beth, you want to start with this one?
Financially viable. Yes. And I'm a community health center. And so there is a large chunk of my patient population that's uninsured or underinsured. And so we do have a fair amount of HRSA, behavioral health, and SUD expansion fund dollars that offsets our patient-generated revenue. And so combined, yes, we are in the black. If I was solely, though, focused on the financial aspect of it, that I think is harder to say, yes, solely we like make ourselves whole. And this is, I think, the piece where Laura was talking about what are those other, though, benefits. And so I'm involved in all of the provider interviews when we're recruiting providers to work at Access, because one of the benefits as a medical provider who we know sees a vast majority of biopsychosocially influenced conditions is to have a team member that they can refer to and work with. So we use it as a recruitment tool. We've also seen integrated behavioral health be a retention tool for our medical providers. And to be totally honest, when I talk with my CFO, to lose a medical provider and the amount of time, right, it takes to hire and to onboard, if you can be a key retention tool, that also has significant benefit. So it's not just, I guess, on the patient-generated revenue piece, but it's these other kind of intangible benefits. And I actually was just meeting with our CFO and our CEO last week, and our CEO made the comment about all of these unanticipated benefits of integrated care. And part of that has been we, as an organization, are stronger. We have better teamwork. We have better communication. We are more direct in our communication styles and collaboration. And that is because of the diversity of our teams and the skills, right, that I think many more interdisciplinary behavioral health teams have. And so I always challenge people, particularly when they're meeting with financial folks, to say, like, here, I'm going to make us whole and here's how, because then you kind of pigeonhole yourself into that's the only value add. And there is so much more value add. And Laura hit on these as well, but also from a patient satisfaction standpoint, we get, sometimes you get different costs for like pay for performance plans if you can do better in your HEDIS measures. So there's all these other ways that I think you can also contribute to the whole outside of just the patient generated revenue. But Laura, I welcome your thoughts.
Yeah, I echo that, Beth. Starting out in a very fee-for-service focused care system, there was a lot of emphasis on reimbursement, like what would be the rate to break even sustainably. We use pilot programming to show in our first year of services that roughly for PCBH, with New York State related reimbursement in our region, so keep in mind it's going to differ where you are in the United States, we were able to roughly break even with a target of 7 to 8 billable patients per day. With collaborative care model, looking at sort of a 50% Medicaid, Medicare, 50% commercial, we were looking at a break even about 60 patients. So constructing our service models to begin with, we really were more so financially like making a little bit back with care management compared to more break even for PCBH. But what we noticed was 95% of our patients who got into CoCM came through BHC. So it was a referral feeder. So we want to be thinking about like if that's kind of the language that we're needing to be able to share with our health systems to begin with, that's helpful. But like Beth's sharing, you can easily get pigeonholed into that is now the only measure that's looked at. So I would say many of us like who are medical professionals, we didn't go to medical school being taught how to do a pro forma. Invest time and energy to learn how to do a pro forma and make sure you're layering in there more than just fee for service generation. That's just one part of it. What we're seeing for our health system, it's a huge recruitment strategy, and there's nice calculators on American Medical Association for retention. It's running on the order of $500,000 to hire and onboard and train, and that's that money, like finding ways to translate into dollar and cents, those added pieces, and that's where your needs assessment, getting that baseline data, and regularly assessing that. That's part of investing in leadership and administrative supports with IBH is very important to capture that value. We know that value is out there, but we have to be able to speak the language to all the stakeholders that we're working with. And that's one of the challenges with IBH. So yes, depending on your region, fee for service generation can be feasible. A lot of this follows Medicaid reimbursement. So New York State, lots of really good reimbursement opportunities, but other states have not turned on those codes. So if you're in an area that's not really a viable option, or maybe you're needing more to make the business case, look at cost savings, look at recruitment and retention, look at satisfaction, and capture that in dollars and cents as well as qualitative data.
I hear the need for some really good performance out there. I hear ya. Always so many questions. Always great when we get to talk to individuals who are boots on the ground doing the work and share how they're doing things, and always more questions. We are out of time for answering questions because I also want to make sure everyone has transition time. Here are some additional resources for those who are interested in just hearing more and learning more about a behavioral health ecosystem. And what that looks like, what the needs are, how to get that going. Those resources are there for you. Those who have been coming to the quarterly webinar series for years now, thank you so much. We are appreciative. We plan to keep it going. Our next one is in October, October 21st, where we'll be discussing a component that aligns with one of the core principles of collaborative care, and that is evidence-based brief behavioral interventions. We'd also like to hear what topics you want addressed around collaborative care for 2026, which I can't even believe that I'm already thinking about 2026 just slightly. But we want to hear from you. That's how we keep this going. That's how we're able to continue to offer this along with experts and colleagues in the field who volunteer their time, but we want to make sure we're addressing topics and issues and concerns and just enhancing knowledge that you all may have. So we encourage you to please fill out our survey, put that information there. Sydney is going to drop the link in the chat box for you, so please click that and fill that out. Again, thank you so much, Dr. Ratzliff, Dr. Sadari, Dr. Zittler-Schreider, and of course my AIM Center colleagues, Sarah and Sydney, for your time today. We love hearing what everyone is out there and doing. And for everyone else, you have some transition time of 2 minutes. Grab water, take care of yourself, have an amazing rock star rest of your day. And we thank you for joining us here at the quarterly webinar.